Good morning, good evening, everybody. It's Katie Pryor here. I'm the Manager of Education Programs here at the PHN, and we're really pleased that you've been able to log in tonight for our webinar. It's a pharmacy webinar on COVID-19 and community pharmacy with Dr. Jacob Williams. Before we get started, I'd just like to acknowledge that we work on the traditional lands of many Aboriginal clans, tribes and nations. I would like to pay respect to elders past, present and emerging, and acknowledge the traditional custodians who care for this land on which we work and live. I acknowledge and respect their continuing culture and the contribution they make to the life of the communities in our region. Just as a bit of housekeeping for everybody, this webinar is being recorded and we will make the recording available on our PHN website and through our regular communiques that are going out twice a week. At the completion of the webinar, there's a short survey that will pop up just to gauge how you found the webinar, what your key take-homes from the webinar were, and any further learnings or further comments that you have. So please take a moment to do that survey. If you don't have time this evening, it will also get resent to you tomorrow. So we always appreciate your feedback, so please take a brief moment to do that. Now, I'm sure everybody is attending lots of webinars at the moment, but if you haven't used the GoTo platform before, everyone should have a control panel. If you can't see it, up in the top right-hand corner of your screen, there should be a little orange arrow which you can click on that should expand your control panel and open it up and give you all the tools that you can use. Everyone's on mute, and so if you've got any questions or comments throughout the webinar, you can use the little question or the chat box. If you just click on that, type your question in and we'll endeavour to answer as many questions as we can fit at the end of this. I'm sure people have lots of questions, so if there are any questions that sort of come in and we run out of time for, we'll certainly do our best to get those answers to you. And we'd just like to say a really big thank you to Dr. Jacob Williams for his time this evening. He's, as you can all imagine, super busy in dealing with this pandemic at the moment, so we're extremely grateful for his time and expertise. And without further ado, I will pass over to Jake. We'll just get his presentation loaded up here.
Perfect. So thank you, Kate, for that introduction. Thank you, everybody, for joining. I just want to take a moment to acknowledge all the hard work that I know everybody's putting in, both on a whole of health system level, but also on a community level, into making sure that we face the emerging threat of COVID-19 together. And we've already seen a lot of success in terms of how the social distancing measures and the restrictions to people's movement have, helped us to combat this problem and have helped us to get on top of testing. I just want to spend some time talking a little bit about the pathogen itself before we roll into things that might be a bit more materially relevant to the day-to-day operation of your pharmacies. So there's this idea of, terminology is really important, and so some of you may be familiar with the term coronavirus. It gets thrown around a lot. This is the coronavirus or coronavirus infection. And ultimately, I just want to clarify a couple of those points, because coronavirus actually is a relatively common genus of virus. There are several different types, and many, including NL63 and OC43 and 229E, just cause the common cold. So at any one time in circulation in Australia, there are coronaviruses moving among us. However, none of them cause the type of clinical disease that we're seeing with this new virus, which has the proper name SARS-CoV-2, so SARS coronavirus 2, which causes the clinical disease of COVID-19. So in the same way that the influenza virus causes the flu, SARS-CoV-2 causes the clinical disease COVID-19. And so SARS-CoV-2 really came to the attention of the world authorities in about late December. So initially what happened was a series of people who were all shared a common epidemiological link to the Henan seafood market presented to health services in China with this unusual pattern of viral pneumonia. And you can see from this timeline, which is lifted from one of the early publications in The Lancet, that people became symptomatic as early as mid-December. And it took some time for things to filter through. And then eventually they had a cluster of cases that raised a suspicion that perhaps they were dealing with a novel pathogen. This is, of course, a similar region to where the original SARS outbreak took place in 2002. So what they ended up doing was in late December, they used what they called a pan-beta coronavirus PCR. So they took a sample from a patient who had this new syndrome of viral pneumonia and ran it through a test that basically identified SARS-like pathogens, but didn't typically identify SARS itself. And so when they had a positive reading on that result, it became clear that they were dealing with a new strain of virus, one that hadn't been emerged before. That was identified in just before New Year's Eve in 2019, and the next day, the World Health Organization and the Chinese Center for Disease Control were identified, and they dispatched a team urgently to the Wuhan province. By that stage, the cat was well and truly out of the bag because, as we are currently sort of working to control this problem, the issue is really this idea of minimally symptomatic or asymptomatic spread. And if you as a hospital service have identified 10 people in your hospital who have COVID-19 that have required inpatient care, it's likely that there are 100 people in the community who have minimally symptomatic disease and are well on their way to transmitting it throughout the community. And so you can see that by the time things really started to take off, because, like all pandemics in the early phases, it worked on exponential growth, this idea that each person infects 2 or more people. So you've got this doubling time. By the time they managed to lock down the province, things were already escalating very rapidly, and we already had the beginnings of a global pandemic. Sort of just to stretch on from here, obviously we've now seen the virus move cross borders, cross nations, and essentially into a worldwide distribution as part of the global outbreak. Cases as of this afternoon are now globally at 1.925 million. And we anticipate that will continue to grow. The thing is that 1.925 million are really proven tests, so people in a laboratory who have a positive test for coronavirus, and it's likely that due to the testing restrictions and limitations overseas and in settings where the outbreaks are very much advanced, it's likely that the true number is many multiple times that. One of the few places we have good data about the distribution in the community and the amount of cases is Australia, and that's because we've from the outset tested very widely and made testing readily available to everybody who meets that criteria. And so you may have heard the Chief Health Officer say something along the lines of, the only numbers I trust are ours. And I actually think that's got a fair amount of validity to it, because compared to a lot of other jurisdictions, we are testing relatively broadly. And that is part of the reason why this curve, which shows you the number of cases we're seeing in New South Wales by date, is probably a relatively accurate reflection of what's happening on the ground. You can see in the early phase of our outbreak, sort of this mid-late March, people got off, started to return from travel, and things like the Ruby Princess were playing out in our communities. The number of diagnoses from overseas travellers, which is in this light blue line, were extremely extensive. But now we've reached a stage where essentially everybody who has returned from overseas has been or will be in quarantine for 2 weeks. And so the numbers of people coming back into the country are smaller. The number of those people are all being tested when they develop symptoms. And so we can see that this light blue line really is diminishing, and we can expect it to continue to diminish over time. What we're really interested in, though, is these darker blue lines, which are people who have acquired coronavirus either directly from a contact, so someone who is positive, and this is a family member or someone who they've shared a space with who develops symptoms and is tested, or someone who, in the most extreme of cases, develops coronavirus for no good reason, in terms of you have no idea where they acquired it or where they may have had their exposure. And that is the really high risk one, because you can't easily capture those people on an epidemiology level because they are essentially indistinguishable from the common cold. And so the only way to really capture them is to test much more widely than we're currently doing. You may have seen some measures from a public health unit perspective about enhanced local surveillance. So places like Wallara, Lake Macquarie, the Inner West, Liverpool, Westmead, these are now jurisdictions or local government areas where the government has said, test everybody with an upper respiratory tract infection. And of course, the plan is to roll those out where you get a signal that there might be increasing community transmission, because we can no longer rely on the epidemiological risk factors on a statewide basis to say that because someone's been a traveller or someone's had gotten off a cruise ship that they may be positive. This is the distribution of the age groups and gender of our current cases in New South Wales. You can see that the bulk of our cases fall into two groups. So either this young group, this 20 to 30 group, where people are returned travellers, backpackers, people who are highly mobile and likely to be highly cohorted in the early stage of the outbreak in particular, and this other group, this 60 to 70 group. This group of people, and the archetypal person would be someone who's recently got off the Ruby Princess, who acquired their infection overseas through travel and has returned to Australia and has been at high risk for severe disease as a function of their age. So I want to zoom in locally because I think it's important to distinguish between what we talk about when we talk about the state and when we talk about us in the Western Local Health District, because the picture is very different. So the Western Local Health District, this is the number of tests performed, actually stacks up quite well compared to other LHDs of a similar size. If you break that down to a per test done per person basis, Western New South Wales has one of the highest rates of testing per 100,000 residents. It has one of the lower percentage positive tests, that's a better way of putting it, than any other LHD. And that's because we have a very relatively small number of cases, but we're still testing widely for that number. So obviously these cases, Southeastern Sydney, Northern Sydney, Central Coast, they are testing much more widely per 100,000, but that's because they've been tracing a lot of local outbreaks. Places like Far West, Murrumbidgee, Northern and Southern don't have a lot of cases, but compared relatively to us, but we are still testing at a per capita basis at a similar rate, which is really encouraging and is part of why I think we have the ability to trust our numbers, which at the moment look very reassuring. So Western New South Wales LHD, when this was published, had 43 cases. This data is a week old. In the week since that data was published, we've had one new case. We have not had a new diagnosis for about 7 days. So that's the sort of broad public health and pathogen message when it comes to COVID-19. And I want to focus in on transmission because that has a lot of implications for the bulk of what we're going to talk about tonight, which is about things like environmental controls, administrative controls and social distancing, and how you can use that to manage your risk of COVID-19 exposure. So we know that the virus is spread almost exclusively via droplets. We have demonstrated in the lab for SARS-CoV-2 and have demonstrated certainly in other SARS-CoV-2 type viruses like the original SARS outbreak, that when you apply what we call exterior pressure or iatrogenic pressure, so if you use a nebulizer, if you use non-invasive ventilation, if you intubate a patient, the exterior application of pressure or the suction of lower respiratory tract secretions can drive aerosolization, and that's very important because it's got implications for how you manage space. A droplet is very heavy, as I'll talk about, and you can plan a radius in which a droplet will spread. So a person in the community with coronavirus, with COVID-19 will really provide an infectious radius around them of about 1.5 meters to 2 meters based on how the droplets can spread. That goes out the window when you talk about aerosolization because it means that the particles are much smaller, they move much more freely, and they essentially move with the air throughout the environment. We know that from lab studies that when you test the stool of people with COVID-19 that you can detect it in their stool, but what's not clear really is that virus alive and can that virus infect another person? And that remains a subject of conjecture. You may have seen this report out of a study in the New England Journal of Medicine saying that it can survive on some plastic surfaces for up to 72 hours. I would give you that information with a degree of caution because ultimately what that study didn't show is whether that virus was alive and whether it was of a sufficient dose to infect other people. But the main message there is that its ability to survive and be transmitted by surfaces is really an area that needs further study, and so you should treat all your areas with caution and make sure your environmental cleaning procedures are robust. And I'll talk about those in a bit more time. The good news about it is that it's pretty vulnerable to standard disinfectants, chlorine-based disinfectants, peroxide-based ones that are available over the counter will do a very easy job of removing COVID-19 from the environment, and ultimately the standard neutral detergent, which simply removes the organic oils and grease that house the virus in the fomite. Those are, the mainstay of how we manage our environmental cleaning. There's a lot of things we don't know about COVID-19. And so everyone, you may have heard this concern about people who are minimally symptomatic or asymptomatic. And so there's this idea of, well, at any one time, you may not know who in the community has COVID-19. And I'll talk about that in a bit more detail. But ultimately, we don't know what percentage of our total cases are never going to get symptoms in terms of they move throughout the community, spreading the virus with no symptoms, and what amounts of people have the virus for a while, eventually develop some symptoms, but do they shed the virus for 24 hours, 48 hours beforehand? We think that number's closer to 48 hours, but ultimately it requires a lot more cases to be studied in detail before we know this for sure. It's got a lot of implications for how we manage things like personal protective equipment and social distancing. And so we don't know how common these people are in the whole cohort. The estimates are probably somewhere in the realm of 15 to 20% of people will carry coronavirus with no symptoms. And we don't know whether or not that makes them immune. We suppose that it does, but again, a very unclear area. The other thing is always there's a lot of concern about this idea that, well, the test's not perfect. The test's not perfect. Does a negative PCR truly rule out COVID? Ultimately, I think that risk has been overstated. We know that patients who do have coronavirus, particularly later in their disease as they recover, they don't always swab positive, but certainly if you've got someone with typical symptoms and you collect a good specimen, the chance of a truly negative result, meaning the patient is negative, so the negative predictive value, would be considered relatively robust. And what's the correlation between viral shedding and infectivity? So if you continue to swab positive at day 10, day 20, day 30, this has got more of a public health implication. Is that person still infectious? And we know from influenza, for example, that if you test someone every day they have the flu, they will continue to have a positive swab, but they won't be infectious because that virus is likely dead. We haven't had the opportunity to study that in detail for coronavirus. So at the moment, it's very hard to know when a patient who does swab positive becomes non-infectious. So this sort of goes back to what I said on that previous slide about this idea that a lot of stuff needs further clarification. So there's a lot of data being generated from places who have dealt with a coronavirus outbreak, a lot of data out of China, Italy, the United States, and ultimately, under normal circumstances, the kind of data that they're generating, so one hospital, in retrospect, a cohort of 200 people, that would be considered pretty crap data, to be honest. It would be considered to be highly likely to be biased, confidence intervals would be high, and you wouldn't change your practice based on those studies. However, we're dealing with COVID-19 here. It's an emerging pathogen. People are desperate to know more, desperate to inform their responses based on the best available data, desperate to get ahead of the curve. And so we've reached this state where essentially every time a new journal is published, it changes the whole mix of how we talk about this disease. But I think it's important to be mindful that when you hear about a new study or a new option or a new research that's been generated, take it in the whole lot wider context that no one's generating great information here at the moment. What will generate great information is time. And although we have to make the best decisions we can at the moment, it's very difficult to talk about this disease with certainty. So on that, I'm going to talk about this disease with a little bit of attempt to put some certainty in it. So when you do have coronavirus, and essentially the major things I want to take, the second message I want you to take in the slide, essentially it's a cold, a head cold. For a majority of patients, it is minimally symptomatic. And I don't want to overstate the fact that people can get extremely unwell. I mean, we should all treat it very seriously. But what I just want to illustrate here is the clinical challenge about when someone walks into a general practice or an emergency department and says, I've got a sore throat, a cough, and I've had some fevers, telling that apart, coronavirus apart from the flu or enterovirus or adenovirus or any of the other coronaviruses is extremely difficult. And it's the real challenge our health services have, because you need to build a system that captures these patients to stop them from spreading the infection within your hospital, but also uses your resources appropriately to make sure that you don't waste your single rooms, your personal protective equipment on people who have completely unrelated viral presentations. So we know that when you do start off with coronavirus, those symptoms, those non-productive, the non-productive cough, the fever, the non-specific features, in the majority of cases, that's all you ever develop. But in a subset of patients, patients who are older, have a past history of hypertension or might be immunocompromised, there's this tipping point between day 7 and day 10 where you can get a lot worse. And ultimately, that is what lands people in ICU, and that is the major contributor to mortality. You may have heard some discussion about treatments. Certainly, Donald Trump's got some very strong views about hydroxychloroquine with or without azithromycin. As most of what he says is completely uninformed and completely inaccurate. There are trials underway looking at Kaletra. Some of you maybe remember Kaletra as a protease inhibitor used in some of the old HAART regimens for HIV. It's no longer really in common use for HIV, but certainly there's some in vitro data saying it will work, and we will look at that in a trial setting. And hydroxychloroquine is, of course, the one that's very public at the moment. The thing about hydroxychloroquine is that it's got an excellent lab profile. So in vitro in the laboratory, it has an inhibitory concentration for SARS-CoV-2 9 times better than it does for the original SARS. And so it looks really promising, but ultimately the clinical data so far is not exactly very exciting. We'll wait for more robust trials to come out, but certainly it's not a silver bullet. And I know that there's been a lot of discussion about its off-label use for prophylaxis. There is a trial being run out of Queensland to look at giving healthcare workers at high risk of exposure hydroxychloroquine for 4 months in order to prophylax them against COVID infection. Ultimately, I think in that clinical trial, they will have to articulate the ethical issues with giving someone 4 months of potentially toxic treatment for a disease that has an incidence that's extremely low at the moment. And I certainly would discourage anybody either in the medical, nursing or pharmacy community from pursuing off-label hydroxychloroquine as a prophylaxis. It can cause significant retinopathy, it can cause QT prolongation, and it should not be done outside of a monitored environment. So I want to move a little bit into talking about social distancing and what we call the risk assessment and mitigation tools that we have for COVID-19. This is a link that I try to show when I give a presentation about this because I think it's really useful to sort of illustrate the point. I'll try and move down here. So in this simulation, every red ball is an infected patient. Every green ball or aqua ball is an uninfected patient, and all the purple is recovered. So this is what happens under normal circumstances. The balls move as we do randomly throughout society. They interact, they collide, infection is spread, and ultimately you get this peak and trough response. But if you are able to quarantine people who have symptoms or are positive, which is what we're trying to do at the moment with this idea of isolating positive cases at home, isolating return travellers. Balls move equally fast, they move equally randomly, but by walling it off for that little bit of extra time, you're able to delay the spread into the community. It's not isolated, and of course this predisposes a non-dynamic isolation, so you're not actively isolating new positives that escape the initial isolation. And so you've managed to flatten the curve, as the saying goes, and delay the outbreak over time. And this is when you add social distancing. So you can see that some of the balls just don't move. When the balls don't move, they don't crash into other balls. They're reliant on other individuals coming across them. So you can see there, more so than quarantine, social distancing or social isolation allows us to delay the spread even further, flatten the curve even further. And ultimately, by the end of the simulation, you've still got people who are uninfected, which is really important when you start talking about the vulnerable communities like the immunocompromised or the elderly. And so this is what I want to drill into now, this idea of risk reduction and how you best manage it in a pharmacy perspective. And so this is the CDC's hierarchy of controls. And essentially, it's not a public health measure, it's actually an occupational health measure. So it's this idea of how you measure things on a work site or in a lab, how you keep your staff safe. And ultimately, I want to draw your attention to a couple of things. Obviously, there's only elimination of coronavirus is outside our immediate locus of control. The thing to stress is that as you grade from most effective to least effective, way down the bottom here is PPE. Because PPE is only as effective as your use is good. And if you cannot don or doff properly, or you're forced to don and doff multiple times, every time you have to wear a mask with someone, you run the gauntlet. Even the best infection control nurse will tell you that the best risk reduction is to remove yourself from that interaction entirely, which is what the idea of social distancing is. So as I said earlier, respiratory droplets spread in a radius of about 1.5 to 2 meters. Obviously, when you're just talking, you spread a little bit of droplet out as you speak. If you sing, you actually create more droplets. That's why that choir became so problematic in the United States. If you yell, it becomes more problematic because you're summoning up more of your exhaled air, and you're sort of straining your larynx as you do that. And so there's a lot of interesting studies into the dynamics of respiratory spread. But basically, for a majority of cases, you have this 1.5 to 2 meter radius, which is why social distancing is so important. I had someone once describe it to me. They live in New York and they walk down the street. Obviously, there's a lot of cases around, and they imagine in their mind's eye as they're walking down the street that everybody who they pass is smoking. And there's this exhaled cloud of air that you're trying to escape from. And that's sort of this idea that you should be far enough away from someone that if they reached out and you reached out, you couldn't touch hands. Because that way, you're at least sort of 1.5 to 2 meters apart. And this is more effective than any mask, any kind of testing regimen. This idea that if you can keep yourself separate and keep your environment clean, you will be safe. And so I'd encourage you to think about the flow of people through your spaces. So this idea that if a patient comes in with symptoms, how do I get them seen by the staff they need to see, assessed by the staff they need to assess, get them hand hygiene, get them a mask, without having them transit as little as possible through shared spaces, common spaces of your workplace. And so this idea of having a sort of separate, a lot of places, particularly in health settings, have what they call a checkpoint. Some at the front being like, why are you here? Are you here because you have a head cold? Here we have a head cold. Here's a mask. Go directly to this seat in this part of the building and don't go either side. Someone will be with you shortly. And it's sort of that approach to streamlining and separating flow that really does help preserve your environment, because environmental cleaning, as I'll say, is the next major thing. So the other thing about that is respiratory and cough hygiene, obviously making sure that people who cough into their elbow, people who sneeze have tissues, all that sort of simple stuff. But ultimately it's very effective, because if you are able to stop this outward spread of droplets, then it spares your environment, which really is the major risk. So I want to talk about masks, because this is something that I talk about a lot in my hospital, and I'm sure there's a lot of concern about it in the community. And so I just want to be clear about what the role of a face covering is when you're talking about a pandemic. So the take-home message is that until the amount of community spread increases, and at the moment in our region there is absolutely no evidence that there is community spread, and yes, we are testing appropriately, and there is no indication for now that that is the case. Until that happens, there is absolutely no utility to you wearing a mask at work. The whole idea of you as an individual wearing a mask is not to protect you from patients in the community who may be symptomatic. The whole idea, and you may have seen this in the United States, they're advocating for face coverings on public transport and public areas. The whole idea of mandating face coverings is that you don't know what day it is the day before you get sick. So I don't know how I'm going to be well tomorrow. I don't know if I'm going to be sick tomorrow. And we know that with coronavirus, the 24 hours before you become sick is when you can spread the virus without symptoms. And so this whole idea of you wearing a mask is to protect other people from you. It is not to protect you from other people. Certainly a mask used alone without the remainder of personal protective equipment will not prevent you from being considered a contact of a case. So it will not spare you a quarantine if a positive case comes into your facility. It will not protect you from that case if that case is not wearing a mask and there's environmental hand hygiene and you touch your face to readjust your mask. You don't adhere by standard precautions, so hand hygiene, all that stuff. The importance of masks in protecting an individual from being infected by COVID-19 has been severely overstated. So environmental cleaning, more so than any piece of personal protective equipment, is extremely high yield. And it's because ultimately, once you remain 1.5 meters or 2 meters from everybody else in your work environment, the only major threat comes from the environment itself. And so this is sort of the guide. This is taken off the New South Wales Health's website when it comes to advice to community pharmacies. And those of you who've not had a chance to flick through that part of the website, I would encourage you to take a look. It's very straightforward and has a lot of reasonable messages that we'll cover over today. But ultimately, it stresses this idea that you should use a detergent for all your routine environmental cleaning, plus or minus a disinfectant. So detergents are actually great on their own. It's the same reason why soap and water is effective hand hygiene. You don't need a disinfectant. You just need a detergent, because when you're talking about spread from droplets from the environment, they are carried on things called fomites. So they don't exist in their own. They're contained within organic particles such as dried respiratory droplets or bits of oil or dust, and the virus sticks to that and uses that as a transport mechanism. So if you can wash your surfaces or your hands with detergent, then that does most of the job for you. You don't have to kill the virus, you just have to remove it from the environment. And then, of course, when it's available to you, if you've got high-touch surfaces like doorknobs, counters, other surfaces that have a high amount of traffic and unwell patients are touching frequently, then certainly a disinfectant would be warranted. And those disinfectants are easily available over the counter, and things as simple as hospital-grade Domestos or chlorine-based disinfectants are appropriate for high-touch surfaces. But I would stress that it's not mandatory to run a mop through your place with Glen 20 every 20 minutes of the day. So I think I've covered over this in a lot of detail. I think that you can't overstate the importance of hand hygiene. And again, this is where the whole idea of wearing personal protective equipment probably overstates that its importance and diverts people away from the major benefits, which are things like social distancing and washing of your hands, and certainly things like after patient contact, before eating, after using the bathroom, or after you touch a frequently transited surface is the time to be reaching for the hand rub or going for the soap and water. So I thought I'd throw in a little bit here about staff health, because it's certainly something that we're dealing with a lot in a hospital setting. This idea of, well, what do I do if my staff are sick? And so certainly in the hospital setting, we are trying to very much combat this idea of presenteeism, this idea that, well, if you're well enough to work, you should continue to work, because if you go home, you're just letting everybody down. And we've been doing a lot of work trying to unpick that and break that down, because ultimately we are of the view that if you come to work with rhinovirus, even not coronavirus, just rhinovirus, and you take out 3-4 members, on average, everyone with rhinovirus infects 6 other people. So if you take out 3 or 4 members of your team and they have to go down, you're going to quickly eat into your workforce, because we are taking a very strict view of everybody with respiratory tract symptoms, and they are not able to work until they're fully recovered. And the guidance, certainly within New South Wales health facilities, is that anyone with a fever or a respiratory symptom, so blocked nose, sore throat, headache, head cold basically, is getting a test for coronavirus, and they are getting sent home until that test is negative and they're fully recovered. Now, obviously, whether or not you apply the definition of healthcare worker to community pharmacy staff, and I don't mean that in a sort of course you guys work in the health system, of course you're health workers, but the New South Wales Health Guideline doesn't specifically state your group. It says residential aged care workers and healthcare workers. But so ultimately, I can't guarantee to you that if you send a staff member to a general practice or to a fever clinic, they will get tested. But certainly there is an overall push within the health system to be very liberal with our definitions and to test people widely. So I would advocate for your staff to get a test if they do present with symptoms, because ultimately they have a lot of healthcare contact, and also it helps us be clear about the level of community activity. We don't have the capacity to test everyone in Orange or everyone in Bathurst or Dubbo with a head cold, but if we take a random section of the population, say healthcare workers or pharmacy staff or whoever, and test all of them, they're as good a sample as anybody else. And they're a high yield sample, because it will help us capture people who have a lot of contact with the community. So just on this issue of whether or not you get a test. So we have had a lot of employers request things like clearances or proof of a negative, and that's simply not something that we as a health service have the capacity to provide. And ultimately, if your employee is well, they should be able to return to work. The question of whether or not they've been tested for coronavirus is a matter for them. You got to trust that the health system is doing its job in terms of identifying people who require a test. So that's all I really wanted to cover over. That's a bit of a Cook's tour of the COVID-19 and the infection prevention and control issues that I'd hoped might be relevant to your areas of practice. I'm certainly happy to take questions as they arise. I'll just reopen my toolbar here and see if I can see any. Is the R naught for corona still estimated to be 3? Great question. So we know that the R naught changes depending on the situation you place the virus in. So at the moment in Australia, the R naught is 1 or less than 1, because we know that everybody in our current society, the way it operates, with everybody socially distanced and everybody staying at home, everyone who gets infected with COVID-19 on average infects less than one other person because they're totally isolated. In the wider outbreak setting, certainly the numbers that we initially were thinking were more in the frame of 2.5 to 3. I think that as we get more detail about the amount of asymptomatic or minimally symptomatic people that exist at any one time, we think that R naught's probably higher, probably closer to 4. But it may take some time for a proper number to spit out. Really interesting, actually, over the weekend, there was a study published in the New England Journal of Medicine. They admitted 126 women to give, 210 women to give birth in a hospital in the United States. They screened everybody at the door, and 30 women were positive for coronavirus with no symptoms. And so it's estimated that that the amount of asymptomatic transmission is probably relatively high. Oh, yeah, face shields on the counter. Any evidence? Great question. So no, unless, because the whole idea of a barrier is that it acts as a sort of separation for social distancing. Ultimately, I imagine you're talking about a situation where you can't keep someone more than 1.5 meters away. Then if you can't keep someone more than 1.5 meters away and you have to have that interaction, would putting a plastic shield between you and them assist in doing that? Yes, probably, because we know that it wouldn't be as good as this idea of socially distancing, because you know that as people move and drop their head, or they raise their voice or whatever, it may not be 100%, because the air dynamics would sort of could move the droplets around a bit. But ultimately, I think if you don't have another alternative and you have an easy engineering solution like a shield over a counter, then I think that would be not unreasonable. Why was SARS such an different scenario back in the early 2000s? Great question, Liz. So SARS was a different scenario because the original SARS, you weren't infectious until you developed symptoms. So it was very easy from the early phase of the outbreak to basically temperature, and you got febrile much earlier, actually, and much more consistently. So it became very easy in the early stage of the outbreak to ask people about symptoms, and if they had symptoms, you locked them down. And if they didn't have symptoms, you could freely help them move throughout the community. But this particular coronavirus is much more like a lot of the other coronaviruses, a lot of the other respiratory viruses, which is there is a clear pre-symptomatic phase in which you are infectious. It's also probably a bit more infectious generally than SARS-1. Oh, hang on. So where should we be getting our critical official information about rapidly and often changing information as prescription legislation? So far, I haven't got any government or official information, and hearing it all in bits and pieces from various third-party sites and social media. I think the government is doing a shocking job of communicating with pharmacists about recent changes. That's a question from Oliver Keenan. I'll throw that to Matt. Matt, are you on the line?
Yes, yeah, I'm here, absolutely. That's not an unreasonable thing to say. It's been quite widespread. from a lot of pharmacists feeling that they haven't been well supported. There is information coming through. I know that within the PHNs, we're trying to have twice weekly communiques within Western New South Wales and with the other primary health networks. They're definitely doing something similar, where we're trying to compile that information into a digestible format. There is a little bit of miscommunication that's coming through from the federal government comparatively to the state government, and I know that the bodies are working as quickly as they can. I'll say quickly as they can to be able to try and clarify those things. I think for community pharmacists, really it's working within the legalities to the best of your ability, and provided that you're demonstrating that it's for the best patient outcome and you're not knowingly breaking the law for no reason, you're going to be fairly well covered. I know there's a lot of areas within community pharmacy that are quite stressful, but we just need to be trying to maintain that intent of servicing the community and protecting ourselves and the community as much as possible. But I do realise there's a lot of confusion with where to get that information from.
Thanks for that, Matt. I'll move on to the next question from Robert King. What risks are involved in handling the repeat paper prescriptions from the community, and what measures, if any, should we implement? So, good question. So, there is some data that the virus can survive in fomite form on paper for not very long, but ultimately I would say that if someone hands you a paper prescription from the community, you can consider that to be safe, provided you handle it, and then after you handle it, you perform hand hygiene before touching your face. You know, it's the same as anything. Someone handed you cash, and I can see a question about cash further down. The whole idea is that if something comes in from the community into your space and it touches your hands, you should consider your hands to be, you know, to use a term we use in hospital settings, consider your hands to be hot until you're able to perform hand hygiene. And so it's really you've got to break the chain of transmission from an exterior source onto your hands up to your face. If you can manage that chain, and the easiest way to do that is through hand hygiene between touching and then touching your face, that will help protect you. Certainly it's not going to spread outwards from anything exterior into your space, but I think that again stresses the importance of routine hand hygiene. This is obviously a virus, a question now from Christy West. This is obviously a virus that has mutated quickly. If we're looking at a vaccine next year, we're likely that it'll be helpful by the time it's been developed. It's a great question, Christy. The idea of how certainly it was able to make the leap from animals to humans and from humans to humans. That's the sort of the primary mutation. Certainly when you look at the genetic studies that are emerging overseas, when they look at, you know, the virus in Italy versus the virus in the United States versus the virus in China and so on and so forth, there is some branching and some general genetic variation, but certainly not to the degree we would see with something like the influenza virus or the rhinovirus. I think that the question of what a vaccine looks like when it comes is a difficult one to answer because it requires a lot of forecasting. I'm hopeful that any kind of vaccine, even if it has to be annual, like it does for the flu vaccine, then I think that would provide. We've already seen the benefit that can provide our community, and so even if it is something we have to change multiple times in order to stay ahead of the genetic variation in the virus, then certainly it would still be welcomed. Is it expected there'll be adequate supplies of the flu vaccine to meet demand in the current climate? Liz, great question. I don't know the answer to that. Certainly, I think that the flu vaccine is available and is being deployed at a large level. I've not heard any concerns about its supply. I think that certainly the demand will be huge, and we may face some supply chain issues, but ultimately we may have to cross that bridge when it arises. I don't know if one's been forecast. There is a suggestion that we're going to be endorsing multiple doses for people in high-risk groups who get an early vaccine, but again, I don't know how that's going to work with supply.
Sorry, I'll just ask a little question there, Jacob, if that's all right with the flu vaccines. Do you think that the social isolation is actually going to flatten that curve out for influenza as well? So if we've got people are panicking about having an immediate shortage of flu shots, but if everyone's socially distancing, are we going to have a flattening of that influenza? And so should people just sort of settle down and the most at risk be the ones being immunised first, because we're going to have a bit of a flattening of the influenza curve with our social distancing?
So certainly, Matt, all the data on the ground is that the flu season is well behind what it usually would be at this time of year. I know the Public Health Unit has been looking at the flu numbers closely, and we would expect to have a very mild flu season this year for that reason. Ultimately, the problem is that getting the flu shot has been a major part of the public health messaging from government figures and health figures, and so I think that we could argue about whether or not it's necessarily going to be the best year to get your flu shot in terms of how bad a flu season is going to be. But ultimately, I think we probably as a health system need to back up our talk, because we can't tell everyone to get a flu vaccine and then tell everyone to back off once it becomes available.
Oh, no, I agree. No, my point was more if in community pharmacy, pharmacists are having a lot of pressure from customers saying, I need to have my flu shot. If they've got an immediate supply chain saying, look, having your flu shot in a month is still going to be fine for you. If they have it a few weeks later because of a supply chain issue, because of this flattening and the delay of the flu season, it's a little later. If there isn't, they can't get a flu shot this month. If they have it in May or the beginning of June, it's still going to be very effective. So we still should be encouraging them to have it. But if there's that immediate supply chain issue, that we can encourage patients that they should still get it. But if there is a shortage of a delay, it's for this reason, because of the social distancing, it could still be quite effective. Is that?
Yeah, no, totally agree that if there is a supply chain issue and someone says, I really want a flu shot, then I think that it is, and it's not available because of a supply issue, then I think that you make a very good point. And I think I would empower people to say that, which is that, with the current lockdowns, with social distancing, all those measures that you use to protect yourself from COVID, they will work for the flu, and they are working for the flu.
Lovely, thank you.
One more. I don't have my staff, this is a question from Greg Shearing. I don't have my staff separated into two teams, but I have a large area pharmacy so we can physically distance and work in pairs. I'm hoping this will minimise collateral damage from an infection on staff. So it's a great question. So this idea of roster splitting is one that we have used in the health service, in the hospital. And this idea that if you have someone on your team who gets infected and then they generate contacts. What I mean by that is that say someone comes to work on a Monday and then they get sick on a Tuesday, everybody who they spent more than 15 minutes of close face-to-face contact with on the Monday has to be quarantined for 2 weeks as a close contact. And so what a lot of people have done to manage their workforce is meant that there is a total separation of staff, so that if someone gets sick on that Tuesday, they can't have interacted with more than half the staff on a Monday, and so you'll at least have half your staff left as a backup to sort of run the skeleton crew. Ultimately, I think that our experience with contact tracing has shown that in the current environment of social distancing, 15 minutes of face-to-face contact, even with a colleague, is actually quite hard to have, because people are separated and they're moving sort of less. Perhaps it's probably different in community pharmacies, but certainly in a hospital setting, we have cancelled all our meetings. We sort of talk on the phone a lot more, and that sort of helped us. In terms of how if you have a large space, then I think that's the best thing you can do is separate people and sort of encourage people to break up their interactions into smaller ones, or talk on the phone, or break them into teams. I think that makes a lot of sense, because ultimately what you don't want to do is a situation where you've got a staff of 6, they all had lunch together for a couple of hours on a Monday, one of them was sick, and now you've got no staff left on Tuesday. So there's another question from Greg. Being in the building is okay as long as separated. Yes, so you can share a building, absolutely. So what generates a close contact is 15 minutes of face-to-face conversation, or 2 hours in an enclosed space. And so ultimately that enclosed space is not well defined. Depends, of course, on how big your space is. You mentioned it's quite large, and I think that would be okay. Certainly, we've been told by the Public Health Unit that a 4-bed bay in a hospital or an emergency department is not an enclosed space, but a GP's waiting room in a small practice would be considered an enclosed space. So as long as you've got enough space with enough airflow into and out of it, you should be able to separate on your work floor without having to worry about generating contacts. Okay. All right, great. So if there's no more questions, we can wrap it up there. I think I finished a little bit ahead of time, which is good.
Yeah, well, look, I'd just like to say a big thank you to Jake for his time tonight, and thank you all. The questions are really great. If any further come up, please let us know, and we'll certainly do our best to answer those and to support you guys out there in the community pharmacy. In the survey, there are a couple of questions about electronic prescribing and digital health. So if you can answer that as honestly as you can, we will certainly try and help you out there. And if you're not getting our communiques, let us know also, and we'll make sure that we get you added onto that list, because it applies to general practice, it applies to the whole range of primary healthcare workers, but it is got a lot of information on there that's relevant and up to date. But yeah. And our website also, our PHN website has a section just for COVID-19 and has got all the updated resources on that come to our hand. So there's a couple of ways you can get that information. But yeah, have a lovely evening, everybody, and hopefully we'll talk again soon. Thank you.
All right. Thanks for your time, everyone. It's a real pleasure.
Thank you.